Good morning, everyone. Good afternoon, good evening, depending on where you are in the world. Maza just asked if I could share some information with you on WHO's policies, guidelines on breastfeeding in the context of COVID-19, and what some of the implications are for maternal and child health going forward. So I want to just start off by sharing with you what the patient management guidelines are. This has been the beginning of WHO's efforts, is to really focus in on the management of patients who have COVID-19. And we actually published these on March 14th, right around the same time that most of the Western world was moving into its lockdown phase. And so there was a lot of attention to COVID-19. At the time, and the focus on these particular patient management guidelines may have been a little bit lost on a lot of people, at least the general public. They were really oriented more toward the case management. But what those guidelines said, and continue to say, is that feeding of infants really should not be any different whether a mother is COVID positive or not. That we would maintain the standard infant feeding guidelines that we do in general circumstances, that we should have initiation in the first hour of birth, exclusive breastfeeding for any children who are less than 6 months of age, and continued breastfeeding up until 2 years or beyond, with complementary foods being introduced around the 6-month time window. So no change there. But that in the context of the mother being positive with COVID-19, we would also recommend infection prevention and control measures. And that is that she would wear a medical mask when she is taking care of her baby, that she would perform hand hygiene, so wash her hands before and after taking care of her baby, and disinfect any surfaces that she might have coughed on or had any fluids on that the baby would come in contact with. We did recognize in the guidelines that there might be some mothers who were too sick with COVID in order to be able to directly breastfeed at the breast, and that in those situations we would want to support expression of breast milk, both to maintain her own milk as well as to ensure that it could be fed to the baby either by herself if she's able to take care of the baby, although in most of these circumstances the fact that she's not able to directly breastfeed also means she can't hold her baby. That then someone else would need to be feeding that milk to the baby. But the underlying message here is that we do not want to see any separation. There's no recommendation to separate mothers and babies if the mother is positive. And so for newborns, that would mean skin-to-skin contact or kangaroo mother care. For older mothers, it would imply that the mother could continue to provide care for her baby. So we also developed a decision tree that you see here that at the top just kind of reinforces that it makes no difference whether or not the mother is COVID positive or not. As long as she is well enough to breastfeed, then she should breastfeed. The only difference is these IPC measures. If she's been coughing, how to manage that she should wear a medical mask. If the medical mask isn't available, that she should use a tissue and throw that tissue away, that she might need to wash her breasts if she's been coughing on them, but that she doesn't regularly need to be washing her breasts. But then should proceed with standard breastfeeding recommendations. And basically all mothers, we would have that recommendation that they wash their hands, that they clean and disinfect surfaces would just be part of our general guidance to the general public. So those would be applicable to all mothers. But what this decision tree recognized was that there will be some mothers who are not able to breastfeed and are not able to express their milk or are not willing to express their milk. And so we have to look at how would we feed those babies, and what the guidelines said was that the first option we should be looking for is donor human milk. In any context where the human milk would be available from a donor human milk, that would be our first recommendation. Oftentimes donor human milk is reserved for preterm babies, but we felt that this was a context in which the feeding would be very short. Usually it's over the course of about a week, maybe 2 weeks. And so to bridge that baby without having to turn to breast milk substitutes, that the supplies could probably handle the small number of pregnant women or postpartum women who needed that milk. If that's not available in context where wet nursing is culturally acceptable, is allowed, you can find a wet nurse, that would be the next best option, so that we continue to provide an option of the baby receiving breast milk. And only then would we turn to feeding of breast milk substitutes because we did not have any other options available. In all of those latter cases in which the mother was not able to maintain her milk supply, when the mother does get well enough that she could feed her baby herself, we would want to then ask, is she willing to breastfeed, and try to initiate relactation so that we can move back into that box of supporting the mother to breastfeed for continued breastfeeding and protection. So what is the rationale for this? We looked at a number of issues to make this guideline. And the first and most important point was that we have to be thinking about weighing the importance of breastfeeding against the potential risk of transmission of COVID-19. We've seen in a number of national guidelines that have not recommended breastfeeding that they really are only focusing on making sure that this baby does not get a transmission of COVID-19. And they're not thinking, or at least not documenting, anything about the additional impacts that this might have on the mother's health or on the child's health. And when we look at the balance between those two, we felt it was quite clear that the benefits are in favor of continued breastfeeding and maintaining the mother and baby staying together. Some of the background on why we think that the balance is clearly in that direction is, first of all, to date, we have not found the virus in breast milk. And there have not been any documented cases of vertical transmission through breastfeeding. There have been a few newborns that have come down with COVID-19, but they were never able to determine, was this because of breastfeeding or was it due to other potential sources of infection, such as other family members or nosocomial infection. There are different ways that those babies may have gotten it, so we actually don't have any documentation that breastfeeding has been the source. What we also know is that breast milk itself contains antibodies and bioactive factors that may fight against COVID-19 infection if the baby is exposed through a variety of means. It might be if exposed because the mother was coughing on the baby, or also if other family members were around, or if healthcare workers had exposed the baby. The importance of breast milk may be there to protect the baby even against COVID-19 infection. What we found in the past with SARS was that we did find antibodies against SARS in breast milk. That hasn't yet been found in COVID-19 because the antibody testing for COVID-19 is still in its infancy and has not been validated for breast milk. But it is a hypothesis that we would need to look further into. In addition, it's important to recognize that COVID-19 is in infants has been extremely rare. We only have a handful of cases out of the hundreds of thousands, I guess, to a total of over 3 million cases of COVID-19. A very small proportion of those are in infancy. And among children who have been infected with COVID-19, they typically have very mild illnesses. And the very few cases of neonates that have had COVID-19, they also have very mild cases. And so the harms from COVID-19 to the newborn appear to be very limited. Now, we have to recognize we're still very early in this. We don't know if there could be some longer term consequences for those babies. But given the low risk of transmission and what appear to be very mild illnesses, we think that the proven health effects of breastfeeding, both in terms of saving lives and protecting against morbidity, as well as the health effects on the mother, are important that we protect breastfeeding. So we've actually created a number of tools to communicate this to people. We've developed a set of frequently asked questions, a set of 20 questions that try to unpack those guidelines a little bit more in layman's terminology, adding additional information about what to do under certain circumstances, and a decision tree that I shared earlier for clinicians to walk through how would they decide how to feed babies. So this is an additional resource that's available online. The WHO website and its question and answers has additional questions now available about breastfeeding and COVID. We've developed a number of tiles on social media that you see here. Those are also available online as ways to simply communicate through social media sources or posters, ways to get this information out. We know that it has not been disseminated as widely as we'd like, but we're trying to make it as easily accessible both in the guidelines themselves and easy communication materials for people to get this message that we still do want to protect breastfeeding. We continue to work on this topic. It's not as if the guidelines just went out and we're done. We are in the process now of revising the guidelines. Some of the questions we're trying to look at in the new guidelines are, what if a medical mask is unavailable? As I said, we recommend that the mother breastfeed and use a medical mask. But if a medical mask is unavailable, that the hospital doesn't have that, or the clinic doesn't have that, or if she's trying to manage at home, what should she do? And that's a difficult situation, but I think we're pretty clearly coming out with a recommendation that would not be a reason to not breastfeed, that she should still breastfeed even if she cannot wear a medical mask, and that there are other ways that she could look to try to minimize the chance of the water droplets being put onto the baby. That might be a makeshift mask, a homemade mask. I'm sure you're all familiar with WHO's kind of ambivalence about homemade masks, because there's not a whole lot of proof on their effectiveness. But that's one option that we are certainly looking at. Blankets that might separate the mother and the baby while feeding, might be ways to protect that. The tissue that I mentioned earlier as a way to make sure if she is coughing, that there's a stoppage there. Washing the chest has been another question that we're trying to address. Is that necessary? How often is it necessary? If she's been breathing on herself, are we exposing the baby in that context with that lack of separation? What about a mother who doesn't breastfeed? Should we have separation in that context? The current guidelines have been really focused on the feeding aspects of these babies. But we've had a lot of questions about, well, what if the mother didn't want to breastfeed at all, or she was not able to breastfeed? Would that be a reason that we ought to be separating the mother and the baby? And we don't think that it is, but that is something that is being looked at in the new guidelines. We are in the process of developing a clinical modules app for the phone for healthcare workers so that they can have easy access to this information to help with that dissemination, developing a short video on breastfeeding and COVID-19 for communication purposes. We've worked with UNICEF on developing counseling cards and a messaging document. Those are actually available on the UNICEF website. WHO's clearance process is a little more complicated, so our logo isn't currently on that, but do know that those resources available from UNICEF have been developed jointly with WHO. But I want to just close with thinking about not the mothers themselves, but the spillover effects that we might have on breastfeeding outside of the context of a COVID-19 positive mother. And one of these concerns is the increased promotion that we've been seeing around breast milk substitutes. A number of the companies have taken advantage of the pandemic to create new ads that play on mothers' fears about feeding. They're using this as an opportunity to give donations to try to make themselves look good. And how we're trying to help with the food shortages here. We're trying to make infant formula available. Even though this is against the code and is against the infant feeding and emergencies guidance, we know that that's going to create an additional pressure against breastfeeding as that promotion gets ramped up. So a big concern about what the long-term effects can be there. We're also concerned about community programs to support breastfeeding and how those are being impacted by the social distancing issues that have been recommended in communities around the world. If mothers are not able to get together in mother-to-mother support groups, how will they get that kind of support? Community health workers who are going out into the community to support mothers, if they're not able to make those visits because of the limitations on movement, then we're going to have a lack of that critical support that mothers need. We also know healthcare is a key opportunity for supporting breastfeeding and answering mothers' questions about breastfeeding. But we know that there's been a reduction in routine care because of COVID. Some of that comes because of the diversion of healthcare staff to other activities. They might be pulled into treating COVID patients or pulled into testing for COVID, many other healthcare concerns that are being prioritized at the moment. And so we're concerned that there's a reduction in routine breastfeeding support. I've just recently seen some data on what happened in the context of both Ebola and SARS, where use of routine health services went down by 25% in the communities that were faced with it, and use of inpatient services went down by about 40%. So the impacts on the healthcare system can be extremely devastating. But in addition to the services themselves, we know many mothers are actually refusing to go to health facilities because of their fear of being infected if they were to show up at such a health facility where there might be other patients who are COVID positive. And so they're choosing not to get the continued health care and support for breastfeeding that they might normally go to. People tend to go to health facilities when they are sick, but that preventive care tends to be the first thing to go when people are afraid of healthcare systems. And finally, we're very concerned about not only a misinterpretation of the guidelines, but extending the guidelines beyond what they don't even say. And while there are countries that have promoted a separation of COVID positive mothers from their babies, what we're actually seeing is that many hospitals are interpreting this as that there should be routine separation of even healthy mothers from their babies, basically taking the guidelines in general for communities for social distancing and saying we need to protect this baby by keeping babies separate from their mothers. And that has huge implications for breastfeeding, that at the beginning, we're not going to be supporting the continuation of breastfeeding and that early initiation because of that separation going on. So these are a number of community impacts. I think we need to really focus a lot more on these. The number of women who are affected by the patient care guidelines is really quite small. Only a small number of women actually have COVID positive, and therefore it's a small number of babies who are affected. But these spillover effects are effects that are going to affect the general population even when they don't have COVID. And so we could be seeing a dramatic hit on reducing breastfeeding rates over the coming months, and are going to have to really redouble our efforts to support, protect breastfeeding against all of these concerns. I want to thank you for your attention, and be happy to have a longer discussion with you all about the implications for your programs and such. Thank you.